I'm Alan Banks. This is Dr. James Hamill. And in Ireland, UK, and other parts of Europe, you go by first name basis, not doctor, for all kinds of silly reasons. So yeah, it'll be James.
Perfect.
Alan will discuss. James is our big partner over in Ireland. It's Course 3D is a company, and he has basically brought Chrome GuidedSMILE to Europe. And he has done this through a methodology of teaching, education, and then going chairside, which is the beauty of why we're talking today, because it's a 2-hour surgery. We've done this program before. We wanted to kind of refine it because James has been to 350 surgeries, and he's taught all these doctors that have come to his surgery. And part of the nuance of doing this right is actually doing it quickly. And part of it is for the benefit of the patient. Part of it is for the benefit of the doctor, the team, avoiding the chiropractor until you're older.
Business
part of it, absolutely make it financially acceptable.
Yeah.
And then sometimes, pretty often with us, about 35% of the cases, it's double arch.
Yeah.
So it's good to get this thing done in
It
2
is.
hours or less.
Yeah.
Yeah. And you become kind of the master of it. I'll say it because we're going to teach it. So I'll call you the master of it.
Okay. No one's ever called me that before, so it's nice. Yeah, you got to break it down into all its micro components, and then you got to look at each of those. And that's really how you then become hyper efficient at it. Because that's what this is all about, is becoming hyper efficient at the process. And that's what Chrome enables you to do. That's one of the big powers of it. So yeah, you got to learn the system. You got to understand the system. You got to understand the nuances of it. You got to understand what happens when certain things occur. But then you got to look at it critically in all the little bits. And it's not just us. We talk about it as being Chrome as a team event. Can't do it as a one person. It's not a one person show. So you got to think about your team. And then most importantly, you got to think about the person that you're treating, because they're the big unknown. Okay. And they're the bit that adds most of the time. So the management of that person sitting in your chair is a bit I think we often overlook.
I think we want to make that almost step one of this.
Yes.
Because you can plug in GuidedSMILE.
I suppose I don't treat any patients under sedation. So that's one of the first things.
To bring that up.
Okay. Yeah. So I treat them all under local anesthetic. So my view on sedation is maybe not the view that a lot of people have, but it's often used, and I've seen it many times, almost as an excuse not to deal with the patient. Okay. So they go in, bang the patient off so that you don't have to interact with them really. Okay. And I think that the patient can help you get to a much faster surgery if you engage them from the start. So I don't do any sedation at all. All right. It's all under local anesthetic. So one, it adds time pre-surgery and post-surgery. And it also creates more work during surgery because the patient has to be monitored and looked after. And also it adds cost for the patient, and it adds more complexity to a degree. All right. Yes, people are very slick at doing it, but there's another element to the management. So for me to get super efficient at doing it, what I do is I prep the patient, and I look at how do I prep the patient to help me during the surgery. Okay. Rather than me switching the patient off during surgery, which is what most people will, or a lot of surgeons will want to do, just switch them off, be quiet, let me get on with it. And I actually don't think that that's an awful lot faster in terms of, or more efficient. So what I do is during probably the second visit that the patient sees me, quite often it's still the first visit, I will talk to them exactly about the surgery. So I will take them through all the main steps of the surgery. Now, some patients go, oh, don't tell me about it. But I go, I'm going to tell you about it because you need to know this. Okay. And we'll talk about it in a language that they understand and that they can feel comfortable about it. And I will be very upfront with them, and I will say to them, okay, you're going to help me get this procedure done for you. Okay. My job is to get the case done nice and efficiently for you so you can go out the door with your new teeth, and we're going to work together. So I look at it as the patient being part of that team, not as an ancillary item. Okay.
I remember you teaching this in
Yeah. And so if you do that, and then the patient comes on board, I think they're better consented because they maybe have a better understanding of what's going on. And I will talk to them about, okay, so I break it into the stages. I say, we're going to provide you with local anesthetic. Okay, so first of all, with local anesthetic, you need to leave it work for 10 minutes. Okay, a lot of people just numb up, will quickly wash their hands and get going. The local anesthetic hasn't really started to work. So you want to get the maximum benefit out of it. And I will always tell them that I will give them more local anesthetic during the procedure, usually prior to implant placement. So that patient knows that I'm going to do my best to try to keep them numb, so you know what's coming. Okay, and then I will talk to them about the pin guide. Okay, so I may not use that term, but I'll say I'm going to put in the base. and the base is the first part of surgery. And I talk to them about the drilling of the pins.
Right. Because there'll be a surprise.
Yeah, we don't want surprises. Okay. And I make a joke and I tell them that it's like putting up a shelf. I know that sounds a bit odd, but the patient can understand that in their head. Okay. So I take them through and I go, you're going to feel a tap. It's going to be like me putting a shelf on a wall. Okay. So it's going to feel really odd, but we just got to get through it because we got to do it. Okay. And then I'll talk to them about teeth coming out, if there's teeth that come out, and what that's going to feel like if they have, that most people have had teeth out before, so they get an idea. And then
This stage in their dental career.
yeah, pretty much. Yeah. And then I talk to them about the bone reduction if we're doing an FP3 and what's that going to feel like. So vibration, water, noise, sound, taste. Because these are all the things that patients go like.
Pain.
Well, hopefully not.
Probably not.
Yeah.
Usually when you're at the bone, the pain.
So hopefully not. But we'll come back to what happens if there's pain. And the patient has to be prepped for it. So I will never tell them that this is going to be a painless procedure. Ever.
Sure.
And there's going to be some discomfort here. All right. So then I'd go talk about the bone and what what the sensation of that's going to be like. And then also about the implants. And then I said, then we're in the home straight. And then because it's very easy with Chrome to pick the teeth up, load it. And then I take them through all of those steps. So the patient has an idea, not in a huge amount of detail, but they have an idea of the process that we have to do to get out the end. Because a lot of the anxiety for the patient is how far along am I? And when is it going to be over? So as long as they have a roadmap in their head, I'll say we're now at stage 3. They know there's 4 stages.
Yeah. Well, and the surgery part is about an hour or a little more.
Yeah.
Right? So it's not going to, the 2 hour is start to finish.
Yeah. The 2 hour is from the patient arriving into the surgery to the patient going out the door.
That's quick. And that's something that maybe the 2 hour, maybe that needs to come across that way when we're talking about this 2 hour, because it's not a cut to suture or cut to delivery prosthesis.
No.
That's the package.
Yes.
Yeah.
So I like to see the patient coming in, but they're all the consent and all that's all done. Paperwork is done. They're in, and we're going to start at that point. Okay, and then taking them all the way through to say goodbye.
I remember when I came to your course, it was Jimmy.
Yes, that's right.
Jimmy was the patient.
Yes, that's right.
And when I was in the operatory with you, you were talking Jimmy through extractions.
Yes.
And you even said to remember we talked about this.
Yes.
You're going to have a little bit of pressure.
Yeah.
Yeah.
But because it's lovely to be able that at that point when they're actually doing the surgery, it's lovely to be able to say, do you remember when we told you about this? So then there's no surprises. And if it's no surprises, that actually builds a lot of confidence in you as a surgeon from the patient, because they go, oh, I do recollect that. Okay. But the thing about pain, so the other thing I do is I tell the patient that it's not going to be pain-free and that there are going to probably be moments during a surgery where I'm going to have to ask you to dig deep. And I talk...
The digging deep, I remember with Jimmy, was partly the extractions. The other was the last bit of the implant.
Absolutely, the last 2 mils or so. It became challenging to keep. He was a perio patient, and perio patients, soft tissue and tags, they can be challenging to keep on well numb.
And it was a maxilla.
Yes.
And there's undersizing.
Yes.
You use an aggressive implant.
Yes.
So the implant's doing some of the work. And that's the pressure.
Yeah. So, so this dig deep moment thing is really just a really way for me to prep them that at that moment I have done everything I can to get them as numb as possible, but it may not be 100% anesthetized. That's just the reality of it. And this is the bit where now, Alan, we're now going to ask you to dig deep for me. And it's only going to be a couple of seconds, but rather than me then take 20 minutes of going, you're giving them local anesthetic and trying to, you might never get them numb again. It allows us to keep moving. Okay, you've got to keep the case moving. All right, rather than stopping and starting all the time. I like to try to have it. Once I start, I like just to keep on trucking.
And a patient, his perio was pretty bad. His teeth were used, that type of thing. So if you have a patient with severe perio, still never anesthesia. You have a way of...
No, just local. So sometimes we'll give intra-bony injections. Sometimes, it's often the soft tissue bit that's uncomfortable. So quite often, if you're taking the tooth out and you're having trouble with them getting them, again, that can be, this is dig deep, maybe a degranulation burr, try to get the tissue out because it's the tissue that's often uncomfortable. But I would give local injections around the particular site, and that seems to work. Maybe a very short, like Stabiloc type needle into the alveolus, and that will anesthetize enough for me to get the next little bit done.
Gotcha. All right. So Jimmy, as we've been talking about, was a single large maxilla, but double large.
Yeah.
Right. A lot more time. Should be easier to just knock them out and maybe get it, done. But anesthesia, like I said, it's expensive, and it's also, there's a lot of residual in there when you have that anesthesia going on. So even more important to get the 2 hour down.
Yes.
On a double.
Yes.
Yeah.
Yeah.
Any differences? Anything you do tactically differently between?
So it depends. Sometimes it will depend if it's in a dentulous case or a part dentate case. Sometimes I will drill the pins on the lower and do all of that in one go.
Pinning both arches.
Yes.
Take the lower out.
Yes.
Finish the
Complete the upper and then work to the lower. I've yet to do the cases simultaneously, and I have seen some people over here do a simultaneous arch at the time, both arches at the same time. I haven't tried that yet. Maybe I'm
You have to have a big mouth.
yeah. There's a lot. That's a lot going on. And then my only concern about that is because we've talked about the patient as the unknown. What happens if the patient just can't cope? I would rather have one arch done, safe, happy.
Stuck in the middle.
Yeah, because you could find yourself, you could be stuck. Because some of the patients, you can prep them all you want, okay, and it will help massively. Like I've never had to stop a surgery and it'd be incomplete, but you just don't know. Some patients, it's a big thing to have two arches done at the same time.
And frankly, not everybody watching this is going to buy into the to the type of anesthesia.
Oh, absolutely, and I get that.
So maybe this double arch thing, watch the videos on that because it's certainly efficient to do both. But you got to pick you had to have a large amount of
and your team have got to know exactly what's going on because they got to help you through it. And we talked about it earlier on, which is this being full arch fit. So if you're going to do a dual arch, you as a surgeon got to be able to think, can I keep myself absolutely at the top of the game right the way through the whole procedure? And some people just struggle with that, and we've both seen that. So maybe the surgeon is better to do it an arch at a time, but some people can manage two arches very, very easily.
But you can do 2 hours, 4 hours,
Absolutely.
8 to noon, 8 to 1
You're done.
at the most.
Go home at lunchtime.
Yeah, totally.
And the case is done. No hanging about.
You get to the end, things start to get sloppy. The focus is lost. The team, you're losing. I mean, there's lots of things that could happen.
Yes.
So efficiency, there's another reason for this efficiency.
Yes.
Which is a nice segue into the team being prepared. Now, over in Ireland, they call them nurses.
Yes.
Feel free to call a nurse, but it's basically the assistant over here, a surgical tech or a dental assistant.
Yeah.
And to help to prep them, sometimes it's tough for a doctor just getting started with this to prep them on everything about GuidedSMILE. They can go to the GuidedSMILE University.
Yes.
They can become Chrome ninjas.
Yes.
And they can learn everything about everything except the real experience. They can learn they can learn the terminology.
Terminology is really important.
Very much so.
Yeah.
When you put your hand out, you want something to go in that hand.
Exactly.
Because it's what's next.
Yes.
And it's also, this is another neat thing that we've done together is that you have done the room layout.
Yes.
Video.
Yes.
And I think that's actually part of our series.
Yes.
Where you teach a team where everything goes in the room. You want something, if you can, within 2 feet of the mouth.
Yeah. Pretty much whenever I don't want to move, really. I want to do my surgery. Yeah, I can go around the patient. But I don't really want to have to go and walk around because every time we do that, you're losing time. So if we go back and right to the very start of the video where we're looking at all the details of everything, your nurse has to know the steps as well as you do. She or he needs to know what is happening next. And if you can get, that's the bit probably that I see most whenever I go out that hasn't been done. It's all been about the dentist. Okay, and
the dentist went to the course. The dentist learned it. The dentist
and I get it. It's a big thing maybe, and they're doing their first case, and they want to be certain. But the really well organized ones. So I was at one recently where that was probably the best prep I've seen. The nurses knew me before I came in. They'd watched the videos. They knew exactly what was going on. The dentist had taken the time to really prep the team. The layout was exactly as it was on the video. Okay, so that was the detail on it. Everything printed out, and the nurses knew the steps. And the difference that made for stress level and efficiency was significant.
How rough it is it if you're one there to educate and perform?
Yeah.
There's things you want to educate them out. You don't want to educate the room.
No.
It shouldn't be like that.
No. But listen, it's not rocket science to be organized and set up.
It's also repeat.
Yes, everything. It's pretty much, this is paint by numbers. I know that's maybe an awfully bad term to use.
A room layout is paint by numbers.
But it's just the same stuff, same instruments. Everything's laid out. So I think the team has to be really well prepped. And if your patient is really well prepped and your team is really well prepped, you will be able, because I'll have people coming, how can I get to do this faster? And all they're thinking about is themselves. Okay. If they think about because that's the focus. But if they focus on the patient and they focus on the team, this bit then will actually run smoother. I'm talking about the surgeon. It'll run better. And that's how you will start to cut the time down.
Think of a lot of the doctors that you work with historically have probably done something free
Yes.
and then handed it off to a denture and a lab technician in
Yes.
the room.
Yes.
They probably didn't use any type of guided kit,
No.
more than likely.
Yeah.
So there's a lot of things being introduced here in surgery.
Yes.
And to know terminology, what's next, all those things are
Right.
critical. And in a lot of rooms, a lot of operatories are not really geared towards this.
No.
They have a chair, they have a counter behind the patient, they have a counter over there and a sink way over there.
Yeah.
There's nothing right here.
Yeah.
And you see that the offices that do a lot of this, they end up buying a big, the table
The wheel, the trolley.
comes right over the patient.
Yes.
Nice gravity
Seen-
over the patient.
Yeah, I've seen some of that. Not many. Not
Here,
many.
here in the States, you see a lot of it. I mean, it's,
Okay.
it's basically a table on the patient's.
Okay. Yeah.
face.
Yeah.
Everything is laid on there.
Yeah.
Just really close
Yes.
or around.
Yes.
Yeah. You find a lot of doctors stand up during these.
Yeah, probably I would say 70% are standing, I would think. Yeah, more than maybe I would have imagined. I like standing up. I think you can move easier. You can turn right, turn your, I think like bone reduction, you can swing around and see and look. And I think it's better than staying static. If staying static, we can talk about bone reduction. We'll talk about that later on. But yeah, there's negatives to staying totally static in one place.
So doctors prepped.
Doctors
able to
prepped.
do it.
Yeah.
The team is trained.
Yes.
The patient
Is well prepped and understands what's going on.
Yeah.
Those are, for me, the bits that are missed. Patient prep really well, team prep really well. Everything is focused on the dentist. The dentist has got to understand this is a team event and the patient is part of the team. And I think those are the keys to getting this to be more efficient.
Yeah, plug the patient into some education. They can do it autonomously, go graduate. When they come into that room the next time,
Yeah.
using some language that they need to use.
Yeah, yeah. The nurses, you mean?
The nurses.
The nurses, yeah. Absolutely. So when you ask for the pin guide, you don't want them going, well, which bit's the pin guide? You do that on every single item and they don't know what's coming next. The time, 2 hours turns into 4 hours, turns into 5 hours. And we don't want that.